welcome everyone to our the next episode of our webinar series. Thank you for joining us. And tonight we're excited to have Kristin Nuñez talking about family planning. And as we usually do, first I'll introduce Casey, and then Casey will introduce Kristin, and Kristin will share her presentation. So first, Casey is with the NFDF. She's the Senior Program Manager for Disease Education, Awareness, and Community Assistance. And so thank you, Casey, for being here with us again tonight. And if you would like to introduce Kristin, that would be great.
I sure would. We are so pleased today to have Kristin Nuñez joining us. She is a senior genetic counselor for Duke's Women's and Children's Services, providing expertise across maternal fetal medicine, reproductive endocrinology and fertility, pediatric and adult hematology and oncology divisions. She specializes in hematologic conditions with a focus on genetic testing, prenatal diagnosis, fertility, and pre-implantation genetic diagnosis. She supports and provides perinatal bereavement. Kristin was a graduate of Sarah Lawrence College, where she received a master's in human genetics and is currently an adjunct faculty member at UNC Greensboro's genetic counseling program, where Kristin teaches and mentors genetic counseling students. She's also involved in multiple Duke training programs, including the OB/GYN residency, MFM fellowship, and the School of Medicine. We are so pleased to welcome Kristin today. And just before we ask her to start sharing her screen, I want to let you know that we'll be taking questions in the chat at the end. So if you have any questions, feel free to just put them in there as you go, and we'll be sure to address them at the end. Otherwise, thank you so much and welcome, Kristin.
Yes, thank you, Kristin.
Yeah, and Casey and Jerry, thank you for that introduction. It's a lot of words, but basically what you need to know is that I love being a genetic counselor. I love caring for women and their families, and I love prenatal diagnosis. So that is kind of what we're going to focus on today. I was asked by Jerry to provide just some insight for families who may be thinking about starting their own family themselves and how to navigate some of the options that may exist if you yourself have Fabry or have a child with Fabry and are looking to manage a future pregnancy differently maybe than the first. So I know that we have a small number of attendees, but those are usually my favorite because we can get really interactive. And so I hope that you will jump in with questions as they come up. And I also think, Casey, if you can monitor if there's any sort of, if I'm not making myself clear and there needs to be some clarity as well, let me know. So we're going to focus today on preconception and prenatal reproductive options and genetic counseling for Fabry disease. I want to disclose that, give me 1 second here to move my screen, that I do sit on the medical advisory committee for the Foundation of Women and Girls with Blood Disorders, and am involved in the NIH research project looking at hemophilia A and inhibitor development and other omics in a pregnant women population, and have a couple of other research projects as well undergoing. Before I begin, I want to kind of just set some ground rules for this lecture, which is that we all have our opinions about prenatal testing options and how we would use them and what's appropriate for us. And I would like for us to be open to the idea of being respectful that everybody's going to choose something different in their pregnancies, and that really the best thing as a genetic counselor that I can do for my patients who are interested in prenatal diagnosis is to know what is available to them so they can feel informed and decide what's best for them. I also want to start off by saying I have a special interest in hemophilia, which is also X-linked like Fabry. And I want to do a small shout out to all of those X-linked conditions out there, because as you know, we are recognizing that more and more women can be symptomatic with these conditions, and that this does not just affect men alone. And so I think that that's been really progressive in the X-linked community to start talking about how these conditions can impact women and how the challenges that they face in life, like menstruation and pregnancy and childbirth and various stages of their life, how their disease can be impacted by those challenges. So I applaud what I've read online about how you are strongly advocating for women, and that women can be symptomatic and as affected as their male counterparts, and that you're talking about it being X-linked rather than X-linked inheritance, which takes out, hopefully, the misconception that females can't be affected. So that is my little X-linked soapbox that I'll get off of now. If anybody has ever heard me talk about prenatal diagnosis in the community, I follow this phrase: talk early, talk often. So I think when we don't know what exists, it becomes less empowering when we have to make these decisions. So I think the ability to be able to talk early to our young people about options that exist and to talk often removes not only the stigma associated with options, but also allows us to become more empowered about what is important to us. So you'll hear that through my talk today. There have been tremendous advances in prenatal diagnosis and preimplantation genetic testing that exist for multiple genetic conditions. And we're going to talk about this in the context of Fabry disease. So let's first start with preimplantation genetic testing. Now, you may see this in the literature if you're looking it up. It may look at like preimplantation genetic diagnosis, or PGD, instead of T like tango. And that is because we realize that PGT is a better use of the term. We weren't really actually diagnosing anything but screening embryos. And there's 3 different types of PGT. There's PGTM, which stands for monogenetic disorders, which is essentially for those individuals who are interested in testing for inherited genetic conditions like Fabry. Then there's the more commonly used one, which is PGTA, which is for aneuploidy or chromosome conditions. And this doesn't necessarily provide information about the genetic makeup of a baby, but rather the total content of genetic information. So this type of testing would be used for individuals who are interested in knowing about whether or not their baby may have, or their embryo may have, Down syndrome, trisomy 13, trisomy 18. And then a third type of PGT testing that's available is what is known as PGT-SR, or standard rearrangements or structural rearrangements. So individuals who maybe have balanced translocations amongst their chromosomes, who may be at risk for having unbalanced offspring. With Fabry, we would be mostly talking about PGTM. And really, what's happening here, and when we talk about PGT, we're talking about biopsying an embryo that's approximately 5 days of age. So when we think about it, this process begins with IVF, and that IVF involves the woman's egg, the husband's sperm, or the partner's sperm, and they will either inject the sperm directly into the egg, or they will allow the egg to sit in a sort of petri dish with other sperm and allow the best sperm to fertilize it. I would say the majority of fertility centers will use ICSI, or intracytoplasmic sperm injection. And that's where they insert the sperm directly into the egg. They allow that embryo to grow to 5 days. At that point, it's a large clump of cells called a blastocyst. And that blastocyst is made up of 2 different cell types. You have the outer cell membrane and you have an inner cell membrane. The outer cell membrane is called the trophectoderm. And basically what you need to know about this is that the outer membrane and the cell's contents within help to make the baby's placenta. And then the inner cell mass is what actually becomes the fetus or the baby. When pre-implantation genetic testing is done, what the embryologist will do, and you can see the picture on the right-hand side of the screen, this is of a blastocyst, and they make a small laser incision into the membrane of the embryo, and that allows a certain number of cells to herniate out of this small little incision on the surface of the embryo. And what you're seeing is a pipette to the right of that clump of cells, and they're biopsying anywhere between 5 to 10 cells. And then those cells are sent off for the testing that you want. And then the embryo itself is returned to the laboratory and frozen until that embryo gets a diagnosis. So pre-implantation genetic testing allows couples to assess the embryos to determine which embryos are best utilized and only transfer those embryos that would be presumably unaffected. Now, we've talked a little bit about how females can also be affected, but in the case of X-linked conditions, unless otherwise contracted with a couple, with the intended parents directly, they would consider not transferring the affected males. They would consider testing, or excuse me, transferring an affected, a carrier, quote unquote, carrier female, but we couldn't necessarily say whether or not that female would be as affected as an affected male. So pre-implantation genetic testing has been super helpful for my families who are interested in reducing the chance of having an affected child. When you do PGT, it's important to remember that many embryos are never going to make it to the 5-day cell cycle. They may also not result in an implanted embryo that will result in a live-born baby. So doing PGT alone is not a guarantee of a live-born baby, but it does certainly increase the chances. Next slide. So when we start thinking about, well, what if pre-implantation genetic testing is not an option for me? And that could be because morally I don't believe in it. I ethically, some patients will say they feel like they're playing God. Some patients will say, I just don't have the financial means to afford IVF with PGT. What sort of testing could I do during a pregnancy to identify whether or not my baby could be at an increased risk for Fabry or not? And the first prenatal diagnostic test that's available is known as chorionic villus sampling, or CVS. This is typically performed between 10 and 12 gestational weeks of pregnancy, and it can be done in one of two ways. This picture below is actually illustrating what is known as a transcervical CVS. And this is where we insert a thin catheter up the mother's vagina through the cervix and do a small biopsy of the placental tissue. The other way to obtain that biopsy is by inserting a very thin needle through the mother's abdomen directly into the placenta and doing the biopsy that way. So it can be done in one of two ways. Usually the physician will take the safest approach, and that will depend on the placental location, how the uterus is shaped or positioned, etc. When you do this test, there is a chance for a complication that could cause miscarriage. Nationally, we say that risk is anywhere from 1 in 100 to 1 in 150, which is less than 0.75%. So for patients who know that they're at risk for having a child with Fabry and want to think about how they would value that information during the pregnancy, for them, the risk associated with complication may be worth it compared to the risk of having an affected child. Next question. Next slide, please. The other option for prenatal diagnosis is what is known as amniocentesis. And amnio is performed typically after 15 weeks of pregnancy. And this is when both the membranes of the uterus have kind of become stuck together or fused together, and that's called the amnion and the chorion. And this typically happens after 15 weeks of pregnancy. What happens with amniocentesis is we will insert a very thin needle somewhere below the belly button above the pubic hairline. So, contrary to what most people will say, it does not go in the belly button, but somewhere below the belly button above the pubic hairline and go directly into the amniotic sac. And in that amniotic sac are dead skin cells that have fallen off the baby that are just floating in that fluid, which is essentially fetal urine. What we do is collect about 2 to 3 tablespoons of that fluid and then send it off for testing. Like CVS, amniocentesis also presents a risk for a complication that can cause miscarriage. Nationally, we say the risk is 1 in 200, but I've seen that risk go down recently to a risk of about 1 in 600. So again, for couples, families, individuals who are interested in knowing if their fetus has Fabry or not and want to know that during the pregnancy, this can be another viable option for them. And we say that it is performed after 15 weeks of pregnancy. We can perform it up until 34 weeks of pregnancy as well. So this is one of those tests that can be performed throughout pregnancy.
Kristin, I have a question for you.
Yes.
Why would someone choose an amniocentesis over a CVS or vice versa?
Yeah. So I was actually going to talk a little bit about that too, but this is a great time. So some of it is preference. Some patients, I think it depends on how somebody would use information. So for patients who want an earlier diagnosis because they may be really anxious about whether or not their baby could have this condition or would like to better plan for where they should deliver. Should they plan on delivering at a tertiary care center where they can care for mom if mom has the variant or not? So earlier diagnosis can help a family plan better. Other reasons for choosing a CVS over amniocentesis would be maybe that family does not want to continue a pregnancy if they know their baby may be affected by this condition, would prefer an elective termination earlier in pregnancy rather than later. I think the other reason that people would choose amniocentesis may also be because they've just arrived late to prenatal care. Maybe they didn't get to their primary care or obstetrician early enough to be offered CVS. And so later on, we're going to talk about how to build your team as you're thinking about a family plan as well. So these are all things to think about. Great
Talk
question.
early, talk often.
That's right. That's right. Next slide, please. So I also want to talk about the use of a technology that doesn't necessarily diagnose Fabry, but does tell us whether or not a fetus may be at an increased risk for Fabry. And this is a blood test known as non-invasive prenatal testing or cell-free fetal DNA. A lot of the just general community will think about this as the test that tells me if I'm having a baby, a boy or a girl, but it does much, much more than that. This is a blood test that we perform from mom's blood. So we collect a small sample of blood from mom's arm. And in mom's blood, when she is pregnant, there is this mixture of mother's DNA and fetal DNA. And that fetal DNA comes from the cells of the placenta. And much like our cells that break down, release little pieces of DNA as they start to degrade, that same process happens to the cells that cross the placenta and get into maternal circulation. They too will start to break down and release these little pieces of DNA. In OB care, we typically perform this test after 8 weeks, and it allows us to screen the baby to determine whether or not the baby is at an increased risk for Down syndrome, trisomy 13, trisomy 18, or sex chromosome conditions. And these are the most common chromosome conditions that we see at any age, regardless of ethnicity. But what this test does do is it does allow us to predict fetal sex. So much like I spoke about hemophilia and my interest in hemophilia and prenatal diagnosis, For my families that know that they're at risk for an X-linked condition and would consider prenatal testing if their fetus was male, may choose to do this test to even know, is this a pregnancy that is truly at risk and for which I should consider prenatal diagnosis? So in other words, this may be a family that says, I just want to know, is this predicted to be a male child or a female child? If it's a male child, I may consider doing more testing to know with certainty whether or not that baby is affected or not. Whereas if it's a female child, may decide not to. And that is how NIPT can also be used to help a patient navigate those steps moving forward. So Casey, to your point, you said, well, why would somebody choose CBS over amniocentesis? That may not even be their first step. Their first step may be to do this blood test to determine, is this a pregnancy at risk or not? And then with that information, we'll use it as a springboard to make future decisions about whether or not they want to pursue additional testing.
And I think we have a question from Jerry.
Yeah, I have a question, Kristin. So you mentioned that this test may not be diagnostic for the child, but if it was a de novo mutation, then and you found a GLA variant, then it would be diagnostic for the child. Is that right?
So you're saying if the family itself had a de novo?
Yeah, well, I thought you said when you started that the DNA screening may not tell you whether the baby has Fabry because the baby's and the mother's DNA is mixed. But if it was a mother that did not have Fabry and the child had a de novo variant, then it would tell you that the child had Fabry. It would be diagnostic. Is that right?
Oh, no. So this doesn't actually screen for genetic, it's single gene conditions.
Oh, okay.
Yeah. So the reason I highlighted this is solely for fetal sex prediction in assessing whether or not that might be a baby at risk for Fabry.
Okay. Thank you.
But Jerry, you raise an interesting point. Also something you guys are like, you're stealing my thunder here for future slides, but but what you are referring to is what is known as single gene NIPT. And there are some laboratories that are currently doing genetic testing on through this technology to see if a baby may be affected with sickle cell anemia or cystic fibrosis. So I think the future of this technology may also include the opportunity to know whether or not a fetus is affected with Fabry, but we're not there yet.
Thank
And
you.
notably, Jerry, just because we talked about de novo, and prenatal diagnosis can be pretty tricky with de novo because you have to have previously identified it in a family member. So we're looking for mom or dad's genetic testing result when we're thinking about all of this.
Right. So we would, if a child had a de novo event, so nobody in the family has it, that would not, we couldn't actually do that testing through this, but we could test a future fetus to see if it had that same pathogenic variant that that prior child had. So prenatal diagnosis still can be an option for families that have a de novo event.
Okay. Thank you.
Next slide. So we wanted to talk, again, this kind of feels like a buffet of options, right? And it's hard to navigate a buffet sometimes. But I want you to think about what would be the reason that somebody would choose to do one or the other. So let's talk about the clinical applications of pre-implantation genetic testing for monogenetic disorders. Again, the purpose of doing this would be because a family wants to anticipatorily reduce the risk of having a child affected with Fabry, and it can be very effective. PGTM, though, the American Society of Reproductive Medicine, or ASRM, recommends that we clinically confirm all PGT-M results with a CVS or an amniocentesis so that we can make sure that the PGT results were correct, that they've transferred the right embryo, and that there wasn't any sort of error. And then for patients who say, well, I really don't want to do CVS or amniocentesis, let's just do NIPT first. Let's confirm that this really is a male or a female, and then we may consider doing CVS or amniocentesis. But the thing that I wanted to highlight is NIPT is not going to be diagnostic for Fabry. Then the other option for patients who would not consider PGT-M or could not consider PGT-M, there's always the option of a natural conception. And then you could confirm the DNA of the fetus with CVS or amniocentesis. Or again, first consider NIPT, identify as early as 9 weeks whether or not that fetus is predicted to be a female or male, and then consider whether or not prenatal diagnosis is desired. I want to kind of mention something that Casey asked me to talk about, which is sperm spinning. And sperm spinning is no longer really a thing in fertility medicine. What they found out was that so sperm spinning is literally the process of taking the sperm and spinning it so that it segregates into two groups. So if you go back to biology and you think about chromosomes are the structures that are contained within the cells of our bodies. So think about each chromosome like an apartment building, and then the genes are the individual apartments contained within that apartment building. The X chromosome, when we are biologically female, we have more molecular weight, more genetic weight than if we are biologically male. So when they used to sperm spin, you would get the sperm to kind of segregate into two groups, and they would choose the sperm of interest, but they were only right in 60% of cases. And if you remember, you have a 50-50 chance of having a female or male with each conception. So that's not so good. What they have found out, though, is they think actually the process of spinning the sperm, the centrifugation of it, is interfering with the DNA. So all this to say, sperm spinning is out. Pre-implantation genetic testing is in terms of the best diagnosis prior to conception or prior to implantation. Next slide. So this is where I want you to be open. We all have choices. And I think everybody chooses something different in their pregnancies. So patients will say to me often, well, why would I want to do this? Or physicians will say, well, this is just about continuing or terminating a pregnancy when you think about prenatal diagnosis. That's all it is. And if you're not going to terminate, then you shouldn't do any of this testing. After 30 years of practice, I don't believe that. You can look at it in a binary way. Patients either choose to continue their pregnancy or they choose to terminate their pregnancy. But where the beauty and the diversity exists is in why they chose this direction or why they chose that direction. So this is where I want you all to think about what's important to you when you're pursuing these sorts of tests. So one option, yes, you can continue the pregnancy. But the reasons that people will continue the pregnancy is because they want the knowledge to help them guide them and their other family providers, their other physicians, through the remainder of the pregnancy. We talked previously about maybe they would choose to deliver at a tertiary care center because maybe mom is symptomatic and may become more symptomatic. Some babies with Fabry are at an increased risk for preterm delivery, growth restrictions, so smaller babies. So they may want to institute additional ultrasound surveillance. A lot of my patients will say, I need to know because I just need that peace of mind, regardless of outcome, regardless of diagnosis. I just would like to know. And then again, we mentioned it, it's about empowerment, having the knowledge so that they can move forward in preparing for the birth of their child. Then there's also the option of terminating the pregnancy. So all of our experiences are different with genetic conditions. I do think of termination in the setting of a genetic diagnosis as being a very loving decision. I think it's never an easy decision and never made lightly by any patient or family. And they may choose to do that out of the best love for that child and or the impact to the family as well. Then we also talk about adoption. And then finally, some parents would say none of this is something that I feel comfortable with and would choose a child-free living. Next slide. I want to be mindful of time too.
We're okay.
Okay, good. So let's talk about your team. I've read a lot of articles in preparation for this talk, and it certainly made me think about larger projects for other X-linked collaboration. But here's what I think. If you are a woman who is a carrier for Fabry and may or may not be symptomatic yourselves, I think it's imperative that as you are planning for your pregnancy, that you speak with an OBGYN and be referred to a maternal fetal medicine physician. These are OBGYNs who've gone on to do a special fellowship in high risk pregnancies. And I also think that you should ask for a consult with a fertility specialist. These are all things that ideally should be done preconceptionally. I'm going to put a nod in there to a genetic counselor. Maybe you've never been genotyped. Maybe you don't know what your pathogenic variant is in your family. Maybe you're still a little bit unclear about what is the risk to my pregnancy. So I think having the option to speak with a fertility specialist to understand what are my options, how much would this cost, what do I think is within my spectrum of consideration. And Daisy, I see your question. I'm going to answer in just a second. Thank you. But then also a maternal fetal medicine physician, because we do know that sometimes symptoms get worse for women during pregnancy. And so having a maternal fetal medicine physician to consult with that can provide care would be essential. Can you repeat Daisy's question for me, Casey?
The question is, what is the risk for mosaicism with a CVS?
That's a
And
great question.
yeah, and would you know from initial CVS results if there is a risk for mosaicism?
Yeah. Okay. So mosaicism is a fancy word for basically saying there's more than one cell type in the placenta. So typically, these would be cells that might have some type of abnormality, whether it's a chromosome or genetic condition in question, and some cells that wouldn't. Typically, we see mosaicism affecting occurring more with chromosome conditions than we do single gene conditions. In general, we say that the risk of mosaicism is less than 1%. So if we did testing and we saw more than one cell type, so meaning we saw some cells had evidence of this particular chromosome condition and then other cells didn't, we would say that that's mosaicism. In the setting of single gene conditions, I don't see it as often. And it really is hard to distinguish because you're looking at whether or not something is present or absent. You're not looking at every individual cell, right? And they're sort of quantifying it in a single way. So I would still say the risk is less than 1%, but I'm certain, like other genetic conditions, there is evidence of mosaicism that can exist.
And then to extrapolate from that, is there a risk of mosaicism with an amniocentesis?
Oh, I think the risk of mosaicism is always there in theory.
Mhm.
It's just whether or not. So with amniocentesis, would you detect mosaicism for single gene conditions? I typically don't see that. Again, I think of it more as being correlated with chromosome conditions. But can we as individuals have more than one cell type that expresses the proper genetic function and one that doesn't. And a great example of that is X-linked, X inactivation. In women, 50% of our X chromosome, it might be shut off, and then 50% of the other cells are shut off as well. But I typically do not see it. I think it's a good question. I just think that we can't really discern mosaicism for single gene conditions in either amnio or CBS.
In Fabry literature, a female's heart could be affected, but not her kidneys, and so on throughout the body.
Mm-hmm. Okay, so next one. Okay. So I think where we look in the future, one, non-invasive prenatal testing, I think, has the possibility of moving into single gene NIPT. So whether or not Fabry will be on there, I think that comes from groups like yourself that really advocate on behalf of patients. The other thing to remember is I know that there's treatment for Fabry, but a lot of people forget that the treatment doesn't change the genetics of your eggs and your sperm. And particularly in some where there's actually gene therapy, it does not change eggs or sperm. So it's always important to remember that you may be feeling good, but may still be at risk for having an affected child. And the last thing I wanted to tell you about is a lot of people, particularly as they think about fertility testing, will say, well, it's something I can't afford. And there is a new House of Representatives has a new bill under review that will actually mandate certain types of therapies for fertility patients. And there is also, like, if you can go to the next slide. At the very end of those resources, there's an organization called Resolve. And if you go to Resolve, you can actually find out in your state, filter by state, and they will tell you specifically what is mandated that is covered to help with fertility, as well as provide resources for where to get funding. So in addition to what we've talked about, the Resolve organization, here's a list of other resources that can be helpful. The first two, to find a genetic counselor in your area. The American College of OBGYN is helpful to find, obviously, OBGYNs in your area. I think the Society for Maternal Fetal Medicine is most important because they are the ones that would be caring for you during your pregnancy. I will also put a little nod that the majority of women who are at risk for genetic conditions, either themselves or their babies, are often referred to genetic counselors after they get pregnant, after their OBGYN has referred them to a genetic counselor. What I want to try to do is empower you all to say, if this is what I would like to plan for pregnancy, then I would like to seek out a maternal fetal medicine physician or a genetic counselor prior to getting pregnant. Final slide. So just in summaries, I really feel that patients need to understand their genetic risks and reproductive options, and ideally this should occur prior to pregnancy. And I think referring to a certified genetic counselor can be helpful in getting a patient directly to those providers who will help them best. But in the absence of finding a certified genetic counselor, you yourselves can ask to be referred to a fertility specialist or a high-risk OBGYN. PGT and prenatal diagnosis are much more embraced. I've been in this practice for 30 years, and it's much more embraced now than it ever has been. And there's an increased desire to want to access these tests for managing their pregnancies. And then finally, I think that all medical individuals that touch you should be familiar with or know when to refer to empower their patients to know their options. So, in summary, the more we talk, the more often we talk, the more likely this is just to become ingrained in what we know, and hopefully allow you to plan better for your family planning. So I'm going to stop there.
Thank you so much for all that information. That was very helpful. For PGTM, my understanding is that I would require not only my genetic testing results, but also like my parents, like my father's, for example. Is that true? And then if so, is it like you would need a blood sample from them because their report is not enough?
Yeah, that's a great question. So what they're doing is they have to, PGT, you have to establish probes. And this gets a little out of my scope of knowledge because it all occurs behind closed doors in a lab. But my understanding is that it requires not only your blood, so it's not just your test results. What they're trying to do is create probes so that they know that when they're looking at the DNA from the fetal biopsy, that they're really able to identify the presence or absence of this pathogenic variant. So yeah, typically what they require is your parents' blood draws. And then they also require your partner's blood draw.
Okay.
And
Excellent. Yeah, I
the
think
labs usually make that really easy for their patients.
yeah, I think it's just one thing I wanted to make sure that was discussed on today's talk because I know for myself, you know, my with it being an X-linked, and if women are aware, then their fathers are usually very affected. They may be passed away. So useful for them to be aware of that they might need maybe an aunt sample if that exists, or maybe even to bank a sample for the future if they know want to keep that door open.
That's a great point. And it is interesting. I don't know about in your community, but I know in the hemophilia committee, there are many women that still don't recognize the fact that if their father is affected, that, aside from non-paternity, that they would also carry the pathogenic variant.
Yeah. Thank you.
Mhm.
Thank you so much, Kristin, for providing us with a great educational resource to share with our community. And just thank you so much for being here. Good night, everyone.
Good night. Thank
Good
you.
night.